So my name is Dr. Kim Keeton. I started with Zomedica back in March of this year. I actually have 20 years of clinical equine experience. I have my own integrative practice. I practice outside of Athens, Georgia. And I'm going to walk you through some physics and case studies and that sort of thing on shockwave therapy in the horse. So quickly, I graduated from UGA in 2005. I have an undergraduate degree in equine science, so I've been pretty well horse crazy my entire life. I also have a CVA from Chi University, chiropractic or medical manipulation practitioner from Pele or Chi University as well. I've been a PulseVet user, so an electrohydraulic shockwave device for over 15 years. And again, I've been with Zomedica since March of 2025. And I am horse crazy in that I practice and ride. So these are two of my guys on the right. The top is an advanced level eventer and the bottom is a Grand Prix dressage horse. So moving on to less fun things. So basically quick and dirty on what we're going to go through. What is shockwave therapy? How does it work in my patients? Yours should be similar. Indications, scientific evidence for those indications, and then some case examples. We're going to kind of back in and out of things as we go along. So what is a shockwave? It is not related to an electrical shock. So it is not jumper cables or anything to do with electrical shock. It's a little bit of a misnomer that way. So what is it? We know what it isn't. It's a high energy sound wave or impulse produced by supersonic crafts. So or with explosions like lightning or thunder. So things that create a huge change in pressure, gunshots, again, lightning, thunder, and we'll walk through kind of lightning and how that creates thunder and how that then makes a shockwave. So this is one of my favorite kind of examples of a shockwave. So this is obviously a little bit bigger than normal, but that's a shockwave on the right. And those are air or water-filled balloons in water. So similar to cells in our own bodies. So those cells are getting deformed and then reformed with the application of that shock wave or that sound wave. So a shock wave is not. It is not a radial pressure wave, and it is not laser therapy. So a radial pressure wave basically is energy radiates and dissipates very quickly. That's a mechanical energy. It's unfocused. It has a lower efficacy. It has a much lower peak pressure and a maximum depth of only 5 millimeters. So it's not super deep. Laser therapy, I think we all are familiar with that at this point. It's light energy. So that's a lower penetration depth. It can only go as deep as light can go. It's giving you less energy to the treatment area just because it's not giving you a whole lot of depth. You're losing some of that energy to heat, and it requires fairly frequent treatment when compared to sound energy, which is what shockwave is. So on the left here, you'll see, that's your light therapy. So that's light hitting the surface of the ocean. And by the time you get to the bottom of the ocean, obviously it's quite dark because that light dissipates when it hits the surface of the water. Whereas on the bottom right of your screen, you'll see a whale. So whales obviously communicate, whales, dolphins, submarines over long distances with sound. So that is kind of your light and sound. So laser versus sound or shockwave energy. So the physics of a shockwave, I promise there's only one slide on physics. It has an extremely rapid high energy sound wave with basically a very, very fast or steep rise time. So that's equivalent to kind of a positive pressure front. And then on the back side of that, you're going to have a negative pressure dip. Okay, so that negative pressure dip is going to give you cavitation in cells, which we'll explain how that's a positive thing going forward. And then that's demonstrated on that top right-hand screen with the graph. And then the bottom right, you're going to see that blue circle is the defined focal area. So that is the concentration of energy. So that is deposited in the cells when that shock wave or that sound wave happens. So there's several different generators that we see in the veterinary market. So electrohydraulic is, there's one on the market, that's PulseVet by Zomedica. So that particular device, and we'll look at that, you're going to have a very fast rapid rise time and a very large focal zone. And I'll show you a slide in the next that kind of looks at these and how they generate these shock waves. Electromagnetic is another version. Storz makes an electromagnetic device that's utilized in the vet space. Its rise time is microseconds, so it's a little bit slower, and it's a true shock wave at only high energy settings. And looking on that far right-hand side, you'll see the top electrohydraulic has a very large orange. That is your focal zone. So that is the area that you're affecting with the sound energy. So you can see as we go to electromagnetic, you're getting to a smaller focal zone. And then we get into the piezoelectric, which is your third one down. That's your rise time is still nanoseconds, so it's very quick. But your focal zone is getting smaller and smaller as we go kind of through the different devices. And we talked about this a minute ago with radial pressure waves. That is not actually a true focused shock wave. The rise time is milliseconds, so quite slow. It does not necessarily produce a shock wave at any setting. And that energy is completely dissipated, you know, by the time you get to 1 centimeter, generally at kind of 5 millimeters. So that's most equivalent to kind of a pneumatic jackhammer. So a lot of those kind of massage devices that you see on Amazon are very equivalent to a radial pressure wave. So if we can see if technology will support us here. The three different these are the three different devices and a more kind of visual presentation of it. So on the far left, you'll see the electrohydraulic device, and that you're seeing two things happening in that. You've got a spark gap that's that's underwater basically, or in a kind of proprietary medium. That spark gap or that spark plug is creating, that's your lightning, right? So that's happening underwater. You've got lightning that's creating a primary sound wave that's going out, that's by that first kind of green line. And then you've got a secondary sound wave that follows it nearly immediately. And that is with your reflector. So your reflector is sending a secondary sound wave. That's your focused energy. So you can see in that kind of the electrohydraulic on the left, again, you see the orange and the red. Those are your focal zone. So that's the tissue area that you're actually able to affect with that shock wave. And then the middle device is the piezoelectric, and you can see, we'll go back through this and play it again. That piezoelectric, those are piezoelectric crystals that are in a kind of conical shape, and those vibrate, and that is creating piezoelectric energy. And you can see kind of that's focused by way of the actual trode head in the way that those crystals are oriented, and that will give you a smaller area that tissue that you're affecting. And then the electromagnetic on the far right, so that is actually, those are vibration of coils on metallic substance, and so that's actually creating a shock wave very similar to a loudspeaker. So that membrane is actually kind of, you're creating a shock wave across that membrane and affecting a larger volume of tissue than you would be with the piezoelectric, but less tissue than you would be affecting with the electrohydraulic device, which has a primary and a secondary sound wave. Apparently, we're going to watch this again, slightly larger. So again, with the piezoelectro and the electromagnetic devices, those are actually going to create a shock wave as the sound wave gets farther and farther from the device. Whereas with the electrohydraulic, you're getting a true shock wave each time that device pulses. So again, looking at the focal zones, which we ask ourselves, why is it important to know what kind of what kind of shockwave device generator we're using? It's these things, right? The focal size, and the cross-sectional size of the area of tissue that we're able to affect. And so with that electrohydraulic, that volume on the right is the largest volume of tissue that you can affect with an electrohydraulic device, which is 140,000 millimeters cubed. Then we go to the electromagnetic device, which you're getting, again, a smaller tissue size, 61 millimeters cubed. And then the piezoelectric, and this is with a linear trode as opposed to a conical trode, and that's, you're getting 2,476 millimeters cubed of tissue affected. Whereas with a kind of a more conical focuser, you're getting, depending on the device, either 30 or 10 millimeters cubed of tissue affected. So why are focal zones and energy important, right? So that's going to determine our treatment protocol. So again, I'm kind of moving more to piezoelectric and electrohydraulic because those are the two that are available currently in the vet space. So the piezoelectric, you're going to have 750 to 3,000 pulses per treatment with a minimum of 4 to 8 treatments, usually once to twice per week while you're doing those treatments. Whereas with the electrohydraulic devices, you're going to have a pulses per treatment of 500 to 1,000, depending on the treatment area that you're trying to affect, with a total of 1 to 3 treatments every 2 to 3 weeks. So difference, kind of with the focal volume is how much tissue can I affect with it and how many pulses or how many shocks, if you will, it's going to take to get the desired effect. So we've got our high energy acoustic sound wave is transmitted into the tissue, a shock wave, if you will, and that is going to be deposited at areas of acoustic impedance. So areas of acoustic impedance, if we think back to our ultrasound labs and that sort of thing, we know that we're not going to see through bone, we're not going to see through air, and we're not going to see through metal. So any area in the body that has a change in that acoustic impedance, you're going to have an effect on those tissues is going to be greatest where you have a change. So where bone joins to tendon, or where you've got, kind of synovial capsule joining bone, that sort of thing, joint capsule, you're going to have a higher indication or a higher deposition of those sound waves. And then at that point, the kind of deeper cellular effect is you're going to have compressive and tensile stresses mechanically stimulating those cells. So if we go back to this, as far as the sound wave, okay, the shock wave in the pool hitting our cell membranes or the balloon in this case, you'll see those mechanical and tensile stresses as far as that, kind of balloon rapidly expands and contracts due to the sound wave itself. As we go into a little bit of kind of more biochem here, we're going to have that physical shock wave. So the actual shock wave itself is going to stimulate your cells with that physical stimulus to give you a biologic response. And you're going to get a bunch of different cytokines released. One's going to have different effects. So those cytokines you're going to have an effect on increasing your functional capillary density. So that's going to increase your blood flow. So bring good things in, take bad things away. You're going to kind of, in that affecting your endothelial cells, you're going to return a chronic condition to the acute phase. And so you're getting all those kind of acute phase, the positive acute phase proteins. So we like that. You're also going to have a strong effect on bone. So you're going to stimulate bone morphogenetic protein. And so that's going to give you bone regeneration and healing. So again, for the more visual learners in the group, which that would be myself included, you can see on the left-hand slide your different cytokines that you're actually getting. So you're getting your bone morphogenetic protein, your tissue growth factors, your PCNA, your vasoendothelial growth factors, and your endothelial nitric oxide synthase. Your nitric oxide is going to help control inflammation, help your vasodilation. Again, good things in, bad things out. That combined with your vasoendothelial growth factor, you're going to get new blood cells or new blood vessels growing with a neovascularization. Your PCNA, you're going to get endothelial cell proliferation, again, contributing to that neovascularization. TGF beta, you're getting obviously tissue healing, and then your bone morphogenetic protein is osteogenesis. So on the right-hand graphic, again, same thing, kind of a different way. You're decreasing inflammation and speeding your healing. You're getting new vessel formation and increased blood supply. You're getting positive effect on growth factors, so more growth factors are being released. And then you're getting an increase in cellular bone production. So if we kind of move away from school and into kind of clinical practice, I think we all kind of live for that day in vet school, you're going to kind of see a bunch of different indications on this indication chart, if you will, kind of anything from, obviously you can see bone, you can see joints, you can see, all the different soft tissue structures that we can affect. And then we've got some fun things on here, superficial wounds and lungs, and we'll talk about different studies that kind of have contributed to these recommendations as far as treatment is concerned. And each one of these, you'll see, we're looking at, we talked about where you're affecting tissue, where the acoustic impedance changes. So if you think about when lightning strikes, it displaces air, and then you have that air rushing together, and that gives you thunder. And then thunder in the air deposits into the walls of your house and during a thunderstorm, and that's when those walls of your house will rattle. So that's why we want to kind of affect those kind of acoustic impedance change areas, because that's where our shock waves are most effective. So if we go all the way back to kind of the late 1900s, early 2000s, and we talk about indications treated, when shockwave first came out, at least when I was a student, we talked about it a lot with tendon and ligament healing, on the equine side for sure. And this particular study was a study that was done with a total of 10 horses, and each horse then was its own control. So there was a total of 20 limbs involved. They induced a tendonitis with a collagenase. And with that, they basically had the limb that was affected and treated, and then just the control limb that was the limb that was affected but not treated. And they saw in those horses, and they were treated kind of at 3-week intervals for a total of 3 treatments. And those guys basically across the board, in the kind of general impression was that shockwave had a highly beneficial effect on the quality of tendon repair. So I think that's really important in our equine patients, right? Because at the end of the day, we need better quality repair rather than speed of healing. We really care about how well that heals so that we decrease the risk of re-injury. So if we look at another study that was on tendon ligament healing, essentially this was the effects of shockwave on ultrasonographic and histologic appearance of forelimb suspensory ligaments. So these are suspensories, whereas the last study was basically superficial flexor tendons. These are now suspensory ligaments. It's a similar collagenase-induced desmitis models as the last one. And basically they were evaluating the ultrasonographic and histological appearance of these lesions in treated and untreated ligaments. And they were, again, doing 3 treatments, 3 weeks apart. And the ultrasounds of these suspensory ligaments basically showed a smaller % lesion at the maximal injury zone with shockwave. And you had an improved total fibrous alignment score and an improved total echogenicity score. So all in all, it was basically shockwave improved the rate of healing as assessed by ultrasound. If we kind of switch gears and we go away from kind of specific tendon ligament and we look at general foot lameness, this was a study that was done by Dr. McClure and his group, and was looking at, treatment of navicular syndrome with shockwave. So it showed that it was effective in decreasing the lameness associated with navicular syndrome in 81% of horses. So these were chronically lame horses that were unresponsive to conventional treatments. They were diagnosed with navicular by a referring veterinarian and reconfirmed with a complete lameness exam. These guys were treated with a total of 2,000 pulses, 1,000 through the frog and 1,000 through the heel at energy level E6, and that was after soaking the foot overnight. Any more soaking the foot is not necessarily universally advocated. Some people say that if you need to soak it to ultrasound, you need to soak to shockwave, whereas at the end of the day, shockwave is a more powerful energy, and it's going to get through tissues rather than having to get through and return to give you an image on an ultrasound. These guys were followed up with no relapse in out to 12 months, which is pretty strong indication. And 81% of those guys, they were followed out to beyond 12 months without a return to lameness. I think a positive with any of these studies is there were no complications associated with shockwave. And essentially, we should be considering shockwave therapy a viable, non-invasive mechanism to help these navicular horses, or these horses affected by caudal heel pain syndrome, as we now call it. So I think we kind of know all the different differential diagnoses of navicular syndrome, but I think it's a good reminder for us to kind of realize how many structures are in the region of the navicular bone, the navicular bursa, and that caudal heel pain, or the caudal region of the hoof. So all of those structures we may or may not be affecting with shockwave. Certainly the areas, again, where the acoustic impedance changes, where your tendons kind of insert, where you've got all kinds of different bony changes and that sort of thing, and the changes within the bone. So again, you know, if you're using this to kind of direct your treatment specifically and doing it as specifically as you possibly can, then you want to locate that lesion with your ultrasound and then treat it with the appropriate depth trode. So either, you know, through the frog or between the heel bulbs to kind of access those structures, whichever way you can get to it the best. And Dr. Turner told us, since ultrasound and shockwave both utilize sound energy, if you can see it on ultrasound, then you can absolutely treat it with shockwave. So that's something to kind of remember as we go forward with these studies. So this is kind of, we're going to talk a little bit about osteoarthritis or OA, and this is a great kind of visual on what's actually happening with OA. I know, you know, explaining it to clients, we always try and explain what's happening in arthritis. You're obviously, you've got an unstable joint, right? So which is leading to synovitis, which is going to give you an overproduction of macrophages and synoviocytes with synovial hyperplasia. Those macrophages are going to overproduce pro-inflammatory cytokines. We don't like pro-inflammatory cytokines at all. Those inflammatory mediators are going to move into and out of the cartilage and the synovial lining into the joint, and that's going to initiate and drive cartilage destruction, which is the definition of OA. And that's then going to give you chronic pain, inflammation, and disability. And then that is obviously going to kind of keep repeating with that vicious cycle of inflammation, giving progressive joint damage over time. So that's a quick and dirty review of arthritis. So this particular study was a Hawk OA study. So this is all the way back. This was AAP proceedings in 2000. So this is now a very old study, although I don't like to call myself old, but it's old. Basically looking at OA in the tarsometatarsal and the distal intertarsal joints of the horse. So this was 74 horses of varying breeds, job descriptions, ages, etc. And all of these horses were at least grade 1 to 3 lame on the AAP scale. And the positive thing is we basically showed that there was an 80% improvement in at least one grade of lameness with shockwave. And these guys were treated with one treatment of shockwave, and it was done under general anesthesia, and they were using a model to kind of identify and treat very specific areas specifically. Again, this was back in these horses were identified in 97 to 99, so it was a while ago. But those guys, 38% of them improved one grade of lameness and 42% improved 2 lameness grades. Pretty strong, you know, positive effect of shockwave on lower hock joint OA. And so they were doing 2,000 pulses again at kind of the very specific sites identified with fluoroscopy. And none of these horses had increased lameness following the treatment, and there were no serious complications associated with the procedure. So again, another kind of lack of side effects or problems as a result of the treatment. As a result, the conclusion was basically shockwave therapy should be considered a viable treatment option for OA, the tarsometatarsal and distal intertarsal joints. So a little more current study. This is a 2009 study on osteoarthritis in horses. And again, this is a well-established bone chip model. So these guys were kind of your carpal syndrome horses or carpal bone chip model. And they were comparing the treatment to a placebo control, a positive control. So that placebo control was they essentially shockwaved it with a sham device, so it's not actually shockwaves. The positive control was using polysulfated glycosaminoglycans, and then obviously the shockwave group. So you had, I think there were 24 horses in this study. 8 were kind of the placebo control, 8 had the positive control, and that dosing on the polysulfated glycosaminoglycan was our typical 7 doses every 4 days for 28 days. So at that point, your typical kind of adequate, if you will, label recommendations. And then the shockwave group, like I said, got shockwaved twice, I believe. And at this point, the degree of lameness in the horses with shockwaves improved significantly compared to the degree of lameness in the placebo or even the polysulfated glycosaminoglycan treated horses. And these guys improved significantly in that study. So if we go to kind of, another indication that shockwave definitely treats is treating backs, right? So I think we have to remind ourselves the reality about equine back pain is that bute will not fix a back problem. Rest does not help a chronic sore back heal. So, I think any of us that are in equine vet med for any period of time have, low back pain or back pain in general. And certainly the more you sit on the couch, the more it hurts. So these horses don't necessarily need to rest for a sore back. Also, hock injuries don't necessarily cause back pain, and hock injections are not necessarily needed prior to the treatment of back pain. Is that always the case? Certainly not, but I think it's a good reminder that horses can certainly have primary back pain as a cause of lameness or poor performance, if you will. Kissing spines or overriding dorsal spinous process impingement. It doesn't have to be career ending. And I think we all fall into the pitfalls as far as back rads on pre-purchase exam, trying to negotiate prices down based on those. Certainly I think we know it doesn't have to be career ending anymore. And using shockwave can be used by itself with back pain or part of a multimodal treatment plan following the diagnosis of dorsal articular process associated inflammation or spinous process impingement. So when we treat backs, I think it's kind of good to remember, you're moving the probe on midline for your SPI and slightly oblique angle to reach your dorsal articular process. You're using 2000 pulses once generally, so we're not necessarily repeating treatment for these backs. You're using the 35 millimeter trode on midline to kind of affect that supraspinous process impingement, and then you're using your 35 and your 80 millimeter trode. So that your 35 and your 80 is referring to the depth of penetration of that shock wave or that sound wave, if you will. You're using your deeper to get to your dorsal articular processes. Most of these guys are rested for 2 days after treatment, and then they're gradually returned to work over 3 to 5 days. So it's a great option for those horses that are, in the throes of the competition season, dealing with back pain, either primary or secondary. And you may need to repeat that treatment in 4 to 12 months. A lot of these kind of chronic conditions where we're taking that chronic phase of the disease back to the acute phase, those effects are lasting for a period of time before they're relapsing, if you will, back to that kind of chronic phase or that discomfort. And this is data courtesy of Dr. Ken Allen and Susan Johns from VEI. This was a retrospective review of 74 horses treated with shockwave for various back injuries. 89% of those had a positive outcome. About 60% of those were improving for 4 to 6 months following treatment. So pretty positive with affecting backs, because I think, at least in my hands, I definitely was treating backs from a multimodal approach I primarily treat English performance horses. So wounds. I know for me, it's not necessarily the first thing that I reach for when I have a wound is my shockwave device, but some really good research out there to indicate that it's super helpful in that it's going to do it in several different mechanisms. So you're going to get all those cytokines that we talked about, PCNA, endothelial nitric oxide, your VEGF, which are known to kind of lead to neovascularization and decrease that inflammation. You're going to decrease your localized apoptosis and increase your skin fibroblast. We also know that from some studies on the human side that we have strong antibacterial effects by affecting biofilm disruption which makes it a really good option for challenging infections. And again, a lot of these animals are on enteric antibiotics, and if we can shockwave the wound bed or the region around the wound bed, we're going to have at that point those challenging infections. We're going to increase the blood flow, at which point we're going to increase the antibiotic penetration because we're increasing blood flow. So there is actually an equine distal limb study. So this was a shockwave on distal limb wounds. So there's a couple positive things about this study. It was actually done in horses. So it's only 6, so not a ton of horses. And this is a surgically induced wound model. So this is not necessarily a chronically infected wound like the one pictured on the left. And so they're full thickness wounds, and there were only 6 horses, but you've got 4 limbs. So 2 4-centimeter full thickness wounds were created on each of the forelimbs, and 2 3-centimeter full thickness wounds were created on the hind limbs. These wounds were randomized. The treatment group basically received weekly treatments of 1,000 pulses at the lowest energy setting. The healing time for these treated wounds was significantly shorter in the treated group. So it was 76 days versus 90 days for the non-treated group. And basically the findings at that point do tell us that shockwave may stimulate healing of wounds in the distal portion of limbs in horses. So again, the study only used fresh, clean, surgically induced wounds, but certainly anecdotally, shockwave does seem to have a greater positive effect in difficult to treat wounds. And this particular horse on the left of course, belongs to myself. And that wound I did end up treating with shockwave as well as a number of other things, everything we could throw at it essentially, and it did heal eventually. So as a kind of case study, this is a mini that's a 6-month-old American miniature horse attacked by the owner's dogs, of course, because who of us has not treated a mini that was attacked by dogs? It resulted in multiple puncture wounds of the dorsal muzzle and nasal passages in the left proximal forelimb. Again, I think we'd all be thrilled if it was only the muzzle. We'd all look like rock stars, but unfortunately, this mini had the proximal forelimb affected as well. So 3 days after the attack, we would expect this mini was febrile, inappetent, depressed with a suspected Clostridial infection. The wound was debrided at that point and the antibiotics changed. 5 days after the attack, again, lameness continued to increase. Necrosis was happening. The skin proximally and caudally was devitalized. And so the caudal aspect of the limb was cool to the touch. There was copious purulent discharge, foul odor, and at that point, shockwave was initiated. So 8 days after the attack, so this is 3 days after the first shockwave treatment, the mini had an improved attitude, better systemic health, lameness was decreased, the muzzle had decreased swelling and discharge, and the limb had a healthier wound bed, but the skin caudally continued to slough. And you can see that on the images there, where the top image is at 3 days post shockwave, and then you can see where that skin was continuing to slough. That shockwave was repeated twice more, 3 days apart. So again, pretty quick retreatment, but this mini was in-house, and so that was what fitted to the in-house model. 18 days after the attack, the mini was systemically healthy. The muzzle was healed because, again, it's a muzzle. The medications were discontinued. The skin sloughed on the limb, but the wound bed itself was healthy. And you can see that's that middle image where the wound bed is healthy. It's obviously, very angry and large, but it was at least healthy at that point. It was discharged at that point with weekly recheck, and that bottom left image, the last picture, was 32 days after the attack. So I think we'd all be quite happy if we got to that point at 32 days. So this is another kind of chronic wound, as opposed to that last one being obviously an acute one. This is doodlebug. This was a case that Dr. Hugh Worsham in Cumming, Georgia, actually submitted or shared with us. It's a 5-year-old AQHA mare. This was a habernomyosis or a summer sore of more than 1 year duration. It was confirmed with biopsy on several different times. The summer sore, as they do, progressively worsened despite multiple surgical debridements. Ivermectin, moxidectin, corticosteroid, pretty much any lotion or potion you could try and treat this with topically, that was done with Doodlebug. Again, multiple surgical debridements, biopsies, repeat moxidectin, all the things. And then Dr. Worsham pulled out his shockwave machine and administered 2 treatments 3 days apart, only 500 pulses. This is quite a large wound with only receiving 500 pulses. With the RO5, so that's the 5 millimeter trode. Again, at the lowest energy setting. The horse was discharged on day 3, and the owner reports that this summer sore did heal completely after over a year of kind of hanging out on this horse's face. So if we go to, we're kind of switching gears back to lameness. So Orthobiologics and shockwave, I think we're certainly all using and reaching for orthobiologics more and more these days. This particular study is looking at shockwave on bone marrow derived mesenchymal stem cells. So these guys this is a Petri dish study, and it was these stem cells were shocked with 500 pulses on a very low energy setting. And cellular proliferation and trilineage potential was determined. And those things were measured at 1, 3, 7, 14, and 21 days after harvesting. And basically the conclusions at that point, and this was a study from 2020, I believe, was that a single low dose of shockwave does not actually damage the bone marrow-derived mesenchymal stem cells' ability to proliferate or differentiate. So that's a positive. It didn't kill them, didn't hurt them. At day 3, post shockwave, you had an increase in ALPL, indicating a transient osteogenic effect, which might be useful in promoting equine fracture healing. Certainly, kind of those fractures that we don't want to see in the cannon bone and that sort of thing, or putting these stem cells in. I think it's nice to know that we can potentially promote that with shockwave on stem cells that are potentially being put in there. Another study looking at PRP and shockwave, so a different orthobiologic. So this was PRP that was produced from 6 horses. So the positive control in this particular study was a freeze-thaw cycle, which, you know, we're often going to do when we're harvesting PRP and not putting it in directly in the field. An untreated negative control, and then 2 different shockwave groups. So you've got a standard probe, so with a 2 centimeter focal width and medium energy density, and a power probe, which is a 1 centimeter focal width and a high energy density. So these, again, this was done in a Petri dish. After each of the treatments, the samples were centrifuged and the supernatant collected for growth factor quantification of growth factor beta 1 and PDGF beta beta. And so the results, so the concentration of both that underwent a freeze-thaw cycle were significantly increased compared to all the other treatments. Both shockwave groups showed a significantly increased TGF beta concentration, so 46 and 33%, and that's with the standard probe and the power probe when compared with the negative control. And both shockwave groups also showed an increase in the PDGF beta beta concentrations with 219 and 190% when compared to the negative control. Again, that's 219% with the standard probe and 190% with the power probe. So basically that data set gives us an indication that the application of shockwave to PRP increases the expression of growth factors in vitro. Certainly, I know a fair number of us probably put PRP in different lesions and certainly use autologous protein serum in different things as well, which contains PRP. So it stands to reason that shockwave applied over those regions would be helpful as far as increasing our growth factors. And probably one of the most exciting things coming out of shockwave, and this is still, you know, the first study I think was published in 2000. This paper There's a white paper that was published in 2025, and there's a new paper that's currently under peer review. Hopefully that will be included in the AAEP proceedings this winter, looking at different lung indications. I came out of the school of thought that never shockwave and air-filled structure. Dr. Bo Whitaker out of Brazos Valley in Texas actually did this study. This is an EIPH study, his initial, that basically looked at using shockwave on barrel racing horses that were bleeders. So this actually, he got the idea from another practitioner who is on the standardbred racetrack, and he used shockwave in standardbreds very successfully with EIPH. And so Dr. Whitaker decided to carry that on as well with his population of barrel racers. So 42 barrel racers were screened, 21 were included in the study. 13 of those were actually bled at their last race. So the clients noted bleeding, and 9 competed on Lasix before and during the study. And on average, the BAL score was reduced by 1.5 grades after shockwave treatment. So 76% of those improved at least 1 grade, and 47% improved at least 2 grades. All but 2 of the horses that improved at least 2 BAL grades improved at least 6% on neutrophil score. So these are BAL scores that were done pre and post treatment. And overall, there was a positive correlation between BAL grade change and the neutrophil change. So this kind of gave rise to the thought process that a lot of these horses have underlying pathology. So all of the horses that were used in the study actually did have underlying asthma. And the theory was that the asthma was causing the EIPH and the bleeding, which gave rise to the most recent paper that's, again, in peer review using shockwave and equine asthma. So pretty exciting new indication that we can certainly use shockwave on safely and effectively going forward. With that, I'll kind of wrap it up and kick it to Susan to read us some questions. If any of you guys have questions about anything I presented or other shockwave questions in the horse.